Hello and welcome. My name is Sarah, and I will be presenting on workplace violence in nursing practice. My agenda for today will be to identify the problem of workplace violence, or as abbreviated to WPV. I will discuss how WPV relates directly to our hospital. I'll review this issue using the Iowa model revised, and I will review why this method is effective for particularly this clinical issue. So I'm going to start with describing the prevalence of workplace violence in healthcare. Psychosomatics published a QSI study that reviewed the prevalence of verbal and physical acts of violence against healthcare workers in an 894-bed tertiary care urban academic medical center. The study was conducted over the time period of 12 months in 2016. 802 eligible respondents were identified, 54% being a clinical nurse. Now, of note, the study did not differentiate between LPN, RN, BSN, or master's prepared nurses. The prevalence of workplace violence is astounding, but potentially even more alarming are the effects of this violence, with 30% of respondents considering leaving their profession and 60% reporting at least one symptom of PTSD. No wonder there is a healthcare worker shortage and increased prevalence of nurse burnout today. To review some of these statistics, you can see up to 34% of healthcare workers in the U.S. may experience workplace violence within a 12-month period. And there you can see the in-text citation for the study. Highest rates of frequency include ERs, psychiatric floors, general medicine, and critical care units. In the study, only 7.6% of respondents reported any of their abuse using the hospital's incident reporting system. As a side note, there were some that reported to their superiors or to security, but only 7.6% reported it properly to the hospital's incident reporting system, which includes HR, higher level management, etc. When investigating the impact of these events, it was found that 30% of healthcare workers who reported being victims of workplace violence considered leaving their career, as well as 60% of survey respondents who reported workplace violence also endorsed at least one diagnostic symptom of post-traumatic stress disorder. So, what can we do now in regard to workplace violence? So, in a different study that you can see the in-text citation, Samani R et al., and it was covered in 2021. According to a systematic review of healthcare-specific workplace violence published in the Show Journal, there are three main strategies used to address workplace violence in a healthcare setting. So the three categorized options, one of them is standalone training seminars. So this is going to be your 1 day or maybe 2 day training. It is with perhaps security teams or other professionals where they teach you how to respond to different violent situations. So the pros are it's going to be a short time commitment. So it's a single day training or maybe a double day training. It teaches you how to de-escalate patients or coworkers and communicate how to properly report events. The cons of this is that it only trains healthcare workers to react to unpleasant situations. It's very reactionary. It doesn't prevent issues from occurring. It teaches you how to de-escalate already escalated situations, as well as there's little time to absorb such a large amount of material and to practice such a large amount of skills. There's also very little opportunity for the nurse or whoever is benefiting from this education to apply their own input and their own perspective to make it more site specific. The next option is a structured educational program. So the way that the study differentiated this is that it is more extensive and it can usually span multiple days. There are some example programs of this, such as the cognitive rehearsal programs. There's the culture of civility, respect, engagement in the workplace, or acronym crew initiative, etc. The pros of these is that they provide more time for information to sink in, opportunity to cover more information regarding different violence perpetrators, because it's not just patients and their families. Sometimes it's coworkers. Sometimes it's going to be a doctor or someone in a level of in a level of power over you. 40% of CRP, cognitive rehearsal program participants, reported noticeable reduction of lateral nurse to nurse bullying, which can be a very big issue depending on your unit. Some of the cons of this training is that it can take weeks. It's much more extensive than these standalone training seminars. There's still little opportunity for nurse input into the violence prevention. Also, a lot of the times hospitals will need to pay for this, so they can be expensive. The last option is a multi-component intervention. This is what they recommended as the most effective intervention. They use stakeholders in the hospital to create a team of both employees and management to conduct regular walkthroughs of the floors or different scenarios that have been identified as a safety concern or a potential safety concern. This team can create individual initiatives that are site specific, and they lead to regular trainings. According to this article, the Samani R et al. They reported in 2021 violent incident rates decreased during the implementation period from 1.6 incidents per 100,000 hours worked to 1.1 incidents per 100,000 hours worked. That is a significant reduction. And the pros is that this is a conversation between management and staff regarding safety. So there can be a conversation for initiatives such as placing panic buttons, different staff training on very specific scenarios, or creating safety procedures. It offers collaboration between staff and management. The cons is this is going to be an ongoing effort. So this is not going to be an initiative for a couple of weeks. That would be more of a structured educational program. This is going to be ongoing, and it requires a team of stakeholders to be continually involved over a long period. So now we're going to talk about why we're using the Iowa model revised. Um, and the goal would be to decrease the prevalence and the effects of workplace violence in the hospital. This framework, I notice it focuses on questioning current practice. It also encourages healthcare workers to view clinical problems as opportunities for improvement. Also, this model produces a team that is made to address this problem, and it ties really closely with the previous slide that I mentioned. So I wanted to briefly overview this model. You can see the image here and the citation for the copyrights of this image. I do not own it. So we're going to start by identifying the clinical issue. And this can be either a widespread problem in the country, or it can be just a problem in our hospital. And then we're going to state a question. We're going to make a PICO question. We're going to talk about forming a team. We're going to assemble our evidence. We're going to create a pilot, and then identify if the pilot was successful, and then talk about disseminating the results as well. All right. So we can identify the current problem by creating our own staff survey to identify current prevalence of workplace violence and review reported instances in the past 6 months. So that's how I plan to identify this problem, is really having a conversation with management on workplace violence specifically in our area. Our PICO question can be: at our hospital, will utilization of a multi-component workplace violence program reduce the prevalence and the consequences of workplace violence within 12 months? I am not going to choose to identify just verbal or physical violence, and I'm not going to limit to just PTSD symptoms. I would also, I didn't include that in my PICO question because I want to include all of that. So is this a priority? As mentioned in previous slides, this is a major issue in our healthcare system. It affects the nursing care, it affects nurse burnout, it affects the staffing shortage, and the safety and well-being of the healthcare workers on our floor. So I would mark this as a major priority. It should be a major priority of our floor, of our unit, of our hospital. So next, our goal is to form a team. The intention for this team is to involve management, nurses, front desk staff, really anybody who is patient facing and is passionate about increasing safety would be welcome at the table here to create a culture of safety and have a sense of ownership. Next, we would look at the evidence. Now, I didn't want to repeat information that I gave in previous slides, but I did mention prevalence and the effects of workplace violence. So I would really use my information from previous slides for this particular part of the Iowa model. I would also incorporate into that data that is specific to my hospital. So maybe I would create my own survey and have patient-facing healthcare workers volunteer to answer that survey, or I would only look at reported events through my hospital-specific reporting system. Either of those would be options to understand what is going on my specific floor and my specific hospital. So the next step would be to pilot a change. So a multi-component intervention can be trialed by starting the change on one unit. So in my scenario, I'm going to choose medical surgical floor. A small team could consist of a unit manager, charge nurse, RN, LPN. We would conduct walkthroughs of the unit to identify safety concerns. This could be tripping hazards. This could be having a poor protocol in case of patient or family member becomes violent. Are our staff aware of that possibility, and do they know where the exit signs are? Do they know how to contact security teams, etc.? A unit-specific concerns can be identified and a priority list can be made. Training and resources and new protocols can be enacted. And we will also continue to monitor for changes of workplace violence rates. To ensure that we will be able to disseminate our results. So while we are piloting this change, we want to always have in the back of our minds, how are we going to record these results in order to disseminate it? We always have to have that final goal in the back of our mind. Determining the efficacy of our pilot. So after the pilot initiative has been completed, an honest review of the occurrences of workplace violence and its effects on staff need to be evaluated to determine if creating a policy hospital-wide is appropriate. So now I'm going to look at the reported incidents of violence. Now, I do want to make a side note that if we are talking about having our nurses properly report instances of violence, we might actually see the reported rates of violence go up, but that might be not indicative that our pilot is failing, but rather that nurses are properly reporting what's already happening to them. So that would be one area to make sure is very well documented. And then at this point, we would be thinking about how to transfer the success of this pilot to the rest of the hospital. Perhaps the workplace culture is really great on this medical surgical floor, but maybe it's not so in a critical care unit. So what is that going to look like in developing a team? How is that going to look in staff engagement? If we have a lot of temporary nurses coming in, travel nurses coming in, they might not want to take part in such a, like in a leadership role such as that. So it's something to think about, barriers to transferring even if this pilot is successful, to other units. So now we integrate the results, kind of what I was already getting at. If the pilot is successful, we can involve key stakeholders such as hospital administrators, to ensure support for this change. And we also want to make sure that we plan on barriers, or we plan to address barriers that will kind of inhibit its ability to enact on all floors. The best way we can make sure that this change continues long term is we can plan quarterly meetings to ensure that the practice continues. And we also want to continue for changes in workplace violence rates. Be open for change. Just because something works really well in 2023 doesn't mean it's going to work well in 2024. So keeping an idea that we can always change based off of the scenarios that are to come. All right, so next we are going to disseminate the results. One way that we can share results of a project such as this would be I'm thinking a lot of hospitals are systems. So if we are in a hospital system, we can share our results with other hospitals, other clinics in our system to adopt this policy as well if it becomes very successful in our 300-bed hospital. If it also continues to be successful, we can also talk about publishing our findings in a journal or such. So here are my references. You can see the Melnick, Feinout, Overholt book and the two studies that I quoted earlier. All right, that is it for my presentation. Thank you so much for taking the time to listen to me, and I hope you have a great rest of your day.